Hello, and welcome to this Nature.com custom webcast titled Integrated Molecular Profiling of Genitourinary Tumors, Application for Personalized Radiotherapy. My name is Jayshan Karpan and I will be your moderator. Today's webcast is sponsored by HTG Molecular Diagnostics. Headquartered in Tucson, Arizona, HTG's mission is to empower precision medicine at the local level. The company is a provider of instruments and reagents for molecular profiling applications based on HTG's proprietary nuclease protection chemistry. HTG's product offerings include its HTG EdgeSeq instrument, which automates sample and targeted library preparation for next-generation sequencing and a range of microRNA and messenger RNA panels for small sample extraction-free expression profiling. We'll begin today's webcast with presentations from two speakers and end with a Q&A session where we will address the questions that have been submitted by you. To ask a question, just press the Ask a Question button at any point during the webcast and we will answer them at the end of the presentations. It is now my pleasure to introduce today's first speaker, Amy Wen, who is Senior Manager for the Immuno-Oncology Biomarker Development Program at HTG Molecular Diagnostics. And now over to Amy.
Hello everybody. I appreciate everyone joining in to this Nature webinar with myself and Dr. Omar Mian of the Cleveland Clinic. HTG and Dr. Mian worked together to generate some of the exciting RNA expression profiling data using archival, formalin-fixed, paraffin-embedded, small cell bladder cancer samples, and he'll be sharing that data later during the webinar. Before we turn the controls over to Dr. Mian, I wanted to give a brief overview of HTG Molecular, who we are, and what our technology enables researchers like Dr. Mian to do. So a little bit about HTG Molecular Diagnostics as a company. We are headquartered in Tucson, Arizona, and our mission is to empower precision medicine at the local level. In order to accomplish this, HTG has developed our HTG EdgeSeq platform, which allows for multiplexed quantitative RNA expression analysis. This is an automated instrument that you can see on the right-hand side of the slide. Our patented quantitative nuclease protection assay is at the core of this technology, and it is this chemistry that is automated on our instrument. We'll talk a little bit more about the details of that chemistry in a few slides. What's unique about our approach is that it enables extraction-free analysis, and this includes from FFPE, using very small amounts of input material. And by very little, I mean as little as 12.5 millimeters squared of input from a single 5-micron FFPE section. Dr. Mian utilized FFPE samples in his studies with HTG. Our approach is coupled to next-generation sequencing-based detection, which also gives our assay superior sensitivity and dynamic range. We offer laboratory services through our VerIO laboratory, which is based at our headquarters in Tucson, Arizona, and also support local EdgeSeq instrument installation as well. So what does our workflow look like? You simply scrape the area of interest off of an FFPE slide and into a tube, add lysis buffer, and heat. So we truly are a lysin load system. At this point, I'll also mention that we can accommodate other sample types as well, such as plasma, serum, and PAX-gene. The lysed sample then gets onboarded onto the EdgeSeq instrument where our quantitative nuclease protection assay occurs. Once it comes off the instrument, you add tags and adapters specific for the sequencing platform you intend to use on the back end, quantitate, pool, and sequence. We are compatible with Illumina, Ion Torrent, and QIAGEN Gene Reader-based next-generation sequencing systems. From here, we'll take a closer look at what occurs on our instrument, the quantitative nuclease protection assay. This is a schematic of the chemistry of the nuclease protection assay that is occurring on board the instrument. HTG offers a number of different panels, each consisting of protection probes, as seen at the top in orange. These are complementary to the target of interest and are 50, that's 50, nucleotides long in the case of mRNA, or for our microRNA assay, the probes are the length of the entire microRNA itself. These bind to their targets via an in situ hybridization reaction in solution, creating a double-stranded probe target entity. At this point, the instrument adds in S1 nuclease. This degrades any single-stranded excess protection probes and any unbound RNA. The original RNA strand is degraded, leaving only the protection probe. It's important to note here that this protection probe is left in a 1-to-1 stoichiometric amount to the original amount of target that was in the sample. At this point, we add tags and adapters via a standard PCR reaction. These are added via the wing sequences on each protection probe. The adapters are specific for the sequencer you intend to run the assay on, and the tags are used to enable multiplexing of samples across a sequencing chip. We are able to multiplex up to 96 samples at a time. You then simply quantitate the resultant library, pull together the samples, and sequence. So back to the workflow here, let's take a second and look at the data output on the back end. The FASTQ files that come off of the sequencer are transferred back to the EdgeSeq for parsing. Samples are demultiplexed by the unique tags on each one. Then, sequence probes are aligned back to the known probe sequence library. Each probe is quantitated and data is reported in an Excel file that can be used for further statistical analysis. I have a quick example of the data output here just to give you a visual representation of what this looks like. Each sample from the run is represented in a column. In the rows are each of the probes in a particular panel. Negative process control genes are at the top, followed by positive process controls, and then each gene of interest on a particular panel. The numbers in columns under the sample name represents the number of times that particular probe was counted within that sample. This raw data can then be fed into standard RNA-seq data packages for further analysis. To finish up, I'd like to mention the assays we currently have available off the shelf for running either on a local instrument or through our HTG Vario service laboratory. We offer both mRNA and microRNA detection panels. On the mRNA side, our largest current panel is our oncology biomarker panel. This is a systems biology panel that comprises a number of different signaling pathways, oncogenic drivers, tissue-specific markers, as well as genes important for angiogenesis and maintenance of a stem cell-like state. This panel is really multi-purpose and quite comprehensive. It's actually the panel that Dr. Mian used for profiling his bladder cancer samples that he'll speak about shortly. We also offer an immuno-oncology focus panel. This contains 549 transcripts and allows researchers to begin to unravel the immune versus tumor response. We offer a DLBCL subtyping panel that contains 93 lymphoma-related genes. And we also recently released the HTG EdgeSeq Path assay. This covers 470 mRNAs, where the corresponding protein is commonly assessed in pathology labs via immunohistochemistry. Finally, on the mRNA side, we also offer our Lung ALK Plus assay. This is designed to assay common fusions such as ALK, RET, ROS, and NTRK, as well as HER2 rearrangements. This panel is unique in that it is only currently offered through our Vario laboratory. On the microRNA side, we offer a whole transcriptome microRNA assay, which is quite popular for liquid biopsy and assessment of circulating microRNAs in a variety of conditions. And this is using either serum or plasma as your input material. So from here, I'll transition the webinar over to Dr. Mian.
Thanks, Amy. Our second speaker today is Dr. Omar Mian, who is radiation oncologist and physician scientist in the Department of Translational Hematology and Oncology Research at the Cleveland Clinic Lerner College of Medicine. And now over to Omar.
Hello everyone, and thank you for joining us today. My name is Omar Mian. I'm an assistant professor in radiation oncology. I'm a clinical radiation oncologist and physician researcher in the Department of Translational Hematology and Oncology Research at the Cleveland Clinic. And it's my enormous pleasure to be talking to you today on a topic of great personal interest to me, and that is integrated molecular profiling of genitourinary tumors and applications for personalized therapy. I should mention that I am the institutional PI for a Genomic sponsored study evaluating the role of Decipher grid in prostate cancer at the Cleveland Clinic. Slides for this presentation were contributed in part by HTG Molecular, Genomic, and Guardant Health. I won't be discussing any off-label use of any medication or devices during this talk. We're going to be discussing several topics today, beginning with risk stratification of prostate cancers using genomic risk classifiers, a field that's seen quite a bit of very exciting progress in recent years. We'll move on to discuss molecular profiling and genetic signatures in bladder cancer as well. I'll talk a little bit about how we can operationalize some of this emerging genetic information through the development of non-invasive biomarkers like circulating cell-free DNA. And then we'll talk a little bit about integrating genomic information with available clinical and dosimetric data that we routinely collect to personalize therapy to individual patients. I'd like to start by illustrating a fairly typical clinical scenario for you, and one that might give us an opportunity to explore areas where we have need for better genomic classifiers, where clinical parameters that we typically use, things like clinical stage, pathology scores, and one-dimensional biochemical biomarkers really aren't sufficient. And this is the case of prostate cancer, where typically a patient comes to clinical attention when their PSA rises. That person gets a biopsy, and that establishes a diagnosis of prostate cancer. In the case of high-risk disease or potentially lethal prostate cancer, that patient has several treatment options. They might undergo radical prostatectomy, sometimes followed by radiation, or image-guided, dose-escalated, intensity-modulated radiotherapy, with or without permanent prostate, low-dose rate brachytherapy seed implants, and usually with the combination of androgen deprivation therapy. The treatment is delivered, and typically the PSA drops. And in the case of high-risk disease, if this patient is treated with external beam radiation, they're typically put on androgen deprivation for a long-term course of between 2 and 3 years. For most patients, the majority of patients, their PSA will remain low after this period once they become eugonadal and their testosterone returns to baseline levels. That patient is cured of their disease. And for a subset of these patients, PSA after that period of androgen deprivation, when PSA is uncoupled from disease burden, the PSA will begin to rise again, and that patient will have biochemically recurrent disease. Oftentimes these patients are placed back on androgen deprivation therapy, and their PSA drops again for some period of time before they progress down this pathway to castrate-resistant prostate cancer and can develop bone metastases, suffer a skeletal-related event, and some proportion of these patients will eventually succumb to their disease. This is a scenario where we don't really have a good way of distinguishing at the outset of treatment which patients will be cured of their disease and which patients will go down this pathway towards prostate cancer-related mortality. And I'll also illustrate that even though PSA is considered one of the better oncologic biochemical biomarkers, it doesn't offer us any assistance in this period during which androgen deprivation therapy reduces the PSA to undetectable levels, either following external beam radiation with long-term androgen suppression, or in this period where patients with recurrent disease or at times early metastatic disease are placed on androgen deprivation, where their PSA is dropped to undetectable levels, as PSA is a testosterone responsive gene. So we have this opportunity both to be able to distinguish lethal phenotypes of prostate cancer from those that we were able to cure using genetic testing to stratify patients at the time of diagnosis, and perhaps use that to select or escalate therapy for those patients who may benefit, and the opportunity to use a genomic classifier or genomic biomarkers to better track disease and treatment response. It's worth spending just a minute talking about the treatment paradigm for localized prostate cancer before we're diving into genetic classifiers. Generally, we stratify patients into risk categories based on clinical parameters, including stage, in this case T stage, their Gleason score, a measure of the pathologic features of their tumor, that predict aggressiveness and propensity for distant spread, as well as measures of tumor volume, including the number of positive cores and things such as PSA density as well as PSA kinetics. Men can fall into one of three general categories per the NCCN guidelines, which can then just be subdivided a little bit further into these 5 categories, including very low risk, intermediate risk, high risk, and very high risk disease. I've illustrated them here for you, along with the clinical parameters that define them, and put in kind of general terms how we approach them. For instance, men with very low risk disease are most often going to be offered active surveillance. These days, men with low risk disease are going to be offered active surveillance, and those that elect treatment will often get surgery or brachytherapy, and some proportion will get external beam radiation. Similarly, for intermediate risk disease, all these options are available to patients. In high risk and very high risk disease, surgery is still offered for selected patients. Many of these gentlemen will now go on to get external beam radiation therapy, perhaps with a combination of brachytherapy boosts, and will be offered androgen deprivation therapy as a standard component of their care. However, as you can tell, the treatment paradigm is largely defined by clinical parameters that are inexact in distinguishing which men have potentially lethal prostate cancer. For instance, low-risk men who are observed who may harbor a variant of their prostate cancer in some small subset of their tumor, which at the outset is heterogeneous in its character, as well as men with intermediate risk disease who perhaps some proportion of whom can be observed safely. How do we distinguish those men from those who need treatment? Who needs androgen deprivation therapy? Following a radical prostatectomy, which men are going to need adjuvant radiation? Which men are going to need androgen deprivation? What duration of androgen deprivation? And even in the case of metastatic disease, we ask the question, can select men with low volume metastatic disease benefit from local therapy, and can some of them achieve a PSA 0 potential long-term durable control? Also, selection of the exact anti-androgen therapy for men with castrate-resistant prostate cancer that emerges under selection with testosterone-lowering therapy. These are areas in which genomic risk stratification really has a role to play, in which we can look at tumor biology in a different way and not be limited by the constraints of, again, as I described, these one-dimensional clinical parameters like stage, pathologic features, and serologic biomarkers like the PSA. And this brings us really to the central point of the webinar today, that emerged from this understanding that tumor biology, driven by tumor genetics, is what determines outcomes. And this was coupled by the convergence of sophisticated technologies that allowed sequencing and expression profiling to a very precise level of any individual's tumor, leading to genomic classifiers, for instance, the Decipher 22 gene test, that can better risk stratify patients, for example, patients with prostate cancer, either at the time of biopsy or after radical prostatectomy. So how do these classifiers perform? Well, in the case of the Decipher biopsy score, which again is a 22 gene expression classifier that is used by profiling the expression pattern using a microarray technology from either tumor biopsy tissue or prostatectomy tissue, using this 22 gene classifier and distinguishing from it a low, intermediate, or high risk score, and comparing that performance of that risk stratification to the one you get from the conventional NCCN criteria defined by stage, PSA, and Gleason score, we see that the Decipher score very nicely distinguishes those three groups and actually does a better job in the high-risk category of predicting both prostate cancer progression to metastatic disease and prostate cancer-specific mortality. And in the case of prostate cancer-specific mortality, arguably one of the more meaningful endpoints in prostate cancer outcomes, the Decipher classifier, specifically Decipher high risk, is able to significantly predict those men with lethal prostate cancer, whereas NCCN risk categorization does not do as good a job of distinguishing men who will progress with lethal disease. And this bar chart illustrates that a score derived from 22 genes, the Decipher score in this case, alone is a better predictor than NCCN risk stratification alone, preoperative PSA, or biopsy Gleason score in predicting risk of metastasis at 5 years, and the combination of Decipher with the NCCN categorization only marginally improves on Decipher alone. So what about the postoperative setting? Historically, men who'd had a prostatectomy who had high-risk features, including extraprostatic disease or a positive surgical margin, were offered adjuvant radiation. But the randomized trials that supported this came in an era that when we didn't have an ultra-sensitive PSA and themselves didn't really incorporate PSA testing to the same degree as we have today. And so this question has emerged that's now being tested in the current group of randomized trials, and that question is whether or not men following a prostatectomy need immediate adjuvant radiation if they have high-risk features, or if these men can at times be observed until they have a PSA recurrence. And at the time of a PSA recurrence, the additional question emerges, which men need androgen deprivation therapy, again based on randomized trials that show a benefit with androgen deprivation therapy, but with heterogeneous enrollment criteria where it's not entirely clear which men need ADT and for how long. And so using a genomic classifier, again the Decipher score based on 22 genes, we see that in those men who have a Decipher genomic low risk score, there's no penalty to foregoing adjuvant radiation and instead delivering salvage radiation at the time of PSA recurrence. However, in men, here on the right side of this figure, who have a genomic high-risk score by the 22 gene classifier, there's clearly a difference in waiting to deliver salvage radiation for men who have adverse features at the time of their prostatectomy. In these men who harbor potentially more aggressive prostate cancer as determined by their genetic features, immediate adjuvant radiation may be more appropriate. And similarly, we see that by using a genomic classifier, we can reduce the number needed to treat to prevent one metastatic recurrence from 10 patients using clinical parameters only to a much smaller 3.1 patients to benefit one using genomic integration. And finally, in those men in whom we would consider the addition of some form of dose intensification, in this case androgen deprivation therapy, we can see that in a group of men who were not given androgen deprivation therapy at the time of their adjuvant or salvage radiation therapy, a genomic classifier does a good job of predicting those men with high-risk disease who would progress to develop metastasis. And so by using a classifier as opposed to conventional pathologic features at the time of prostatectomy, we may be able to better select patients for escalated therapy, including the addition of androgen deprivation therapy, an area of some question now in terms of predicting who would benefit from the addition of androgen deprivation therapy. And so to summarize, genomic classifiers, and I've used here the example of the Decipher 22 gene assay, looking at gene expression. Genomic classifiers of biopsy tissue as well as prostatectomy tissue does an excellent job when compared against clinical features in distinguishing more aggressive variants of prostate cancer, as well as identifying those men who harbor potentially indolent disease that can be observed safely. And so I want to move on from this to discuss more broad examples of molecular subtyping in prostate cancer, and specifically this recent study of the association of luminal and basal subtyping of prostate cancer with prognosis by this multi-investigator group, who asked the question, is luminal and basal status clinically relevant in prostate cancer using the PAM50 clustering algorithm that's been used in a variety of tumors, but most notably breast cancer. And I think these findings are really rather interesting. The first thing you can see is that using the PAM50 clustering algorithm, prostate cancer, like breast cancer, separates very nicely into three groups, luminal A, luminal B, and a basal subtype, and that these three groups have very distinct behavior with respect to biochemical recurrence-free survival, as well as distant metastases-free and overall survival. And it's interesting to note it's the luminal B subtype that seems to have the worst overall prognosis. And in addition to this, we can note that the luminal B subtype seems to be, at least in this retrospective study of nearly 3,700 patients, this luminal B subtype is the cohort of prostate cancers that seem to respond most effectively to the addition of androgen deprivation therapy, and that luminal A and basal subtypes seem less inclined to respond to the addition of androgen deprivation. So we see here a very actionable and clinically meaningful distinction based on a luminal and basal subtyping. And so this represents yet another example of molecular profiling to distinguish prostate cancer into clinically meaningful groups. And I would just add here that this is a retrospective study and prospective validation is needed, but so far very promising to think about characterizing prostate cancers into these phenotypic groups based on a genetic signature. So I've talked about expression profiling and distinguishing low and high-grade tumors, as well as basal and luminal subtypes. But gene expression profiling just gives us part of the picture, and an important and fundamental difference between benign tissues and low and high-grade tumors is that they harbor different epigenetic modifications, which if you don't look for, you don't see on conventional expression profiling or mutation analysis. And so this is a very nice study from Angela Ting and Jeff Brayson here at the Cleveland Clinic. And they looked at global gene expression profiling by methylation enrichment sequencing, and were able to identify a different pattern of regions of differential methylation in benign, low, and high-grade prostate cancers. And this is important in the sense that differential methylation seems to be at least correlated with and perhaps a driver of aggressive behavior in prostate cancer. So I'd like to switch gears now for a moment and talk about bladder cancer, where we're beginning to apply similar molecular profiling techniques and genomic classifiers to risk stratification in early stage non-invasive as well as muscle invasive bladder cancers. And here we see a nice example of that, again from our colleagues at GenomeDx, who have applied the basal and luminal subtyping of bladder cancer based on gene expression profiling to distinguish four groups: a basal-like tumor in red, basal claudin low, gray, luminal infiltrative, the light blue line, and the dark blue line is the luminal subtype. And several things pop out immediately. We can see with respect to overall survival, the basal-like tumors in the red line have a remarkably different median overall survival with the addition of neoadjuvant chemotherapy. And so once again, we're defining different molecular groups that have dramatically different and clinically actionable variation in their behavior. Obviously, this has important implications for how we'll be approaching classification of bladder cancers down the road, and we're moving towards validation studies prospectively in this area. We also recently presented at the recent ASCO meeting our own efforts to profile a variant of bladder cancer, small cell bladder cancer, which occurs rarely but tends to have an aggressive behavior, more likely to move to nodes and metastasize distantly, and a variant that we extrapolate treatment paradigms from other sites, including small cell carcinoma of the lung. We have a cohort of 63 patients with small cell bladder cancer here at the Cleveland Clinic, 53 of whom were analyzed through immunohistochemical staining for DLL3 and PDL1, and of that a subset had tissue available for expression profiling of both tumor tissue as well as, in some cases, matched adjacent normal bladder tissue and metastatic site biopsies. These tumor tissues were profiled using very exciting new gene expression profiling technology from HTG Molecular that involves essentially an RNase protection assay in an automated format to examine the expression of over 2,500 genes across a broad oncology biomarker panel, having the advantage of not requiring extraction from FFPE tissues, which allows us to measure a higher integrity sample as extraction often leads to degradation of RNA in formalin-fixed and paraffin-embedded tissues. And what we find using the HTG Molecular EdgeSeq assay is that once again gene expression profiling appears to segregate small cell carcinoma of the bladder by unsupervised hierarchical clustering into 4 distinct clusters, and this is confirmed by consensus matrix clustering that shows, again, 4 stable and discrete clusters of gene expression profiling. We find that there's a subset of tumors that cluster with normal tissues, and another subset of tumors that appear to cluster with metastatic site biopsies. And as you would predict, these tumors behave very differently. Our normal-like cluster has excellent overall survival, whereas tumors falling in the metastatic clusters tend to do worse overall in follow-up with respect to outcomes, and specifically with respect to survival. And we're able to confirm by pathway analysis and gene set enrichment that these clusters are characterized by highly significant differential expression of a group of tumor suppressor and oncogenic driver proteins, as you would predict based on the clinical behavior of the different clusters within this subset. And we're now moving to mechanistic studies to evaluate these differentially expressed genes for functional involvement in driving the different behavior of small cell bladder cancer tumors in these good prognosis and poor prognosis clusters. So I hope you're getting a sense that it's an exciting time from molecular profiling. I've tried to give you a little bit of a taste of what's really a much broader effort to characterize the genomic landscape of multiple tumor types, certainly those in GU cancers, and of course more broadly. But I want to spend a few minutes talking about the need for improved biomarkers, and really this gets at the next logical step for molecular profiling, which is to operationalize what we're learning about, again, the genomic landscape of tumors and translate it into improving the outcomes of patients. And one important step in this direction is the development of novel non-invasive biomarkers for detection and screening, of course for risk stratification, as I described for you with genomic classifiers, and for monitoring treatment response in those scenarios where we don't have better biomarkers or where biomarkers that we have are limited. And like many others, we're excited by the promise of the detection of tumor DNA in the circulation, that is the non-invasive identification of circulating tumor DNA amidst the background of cell-free DNA that exists in the plasma of patients with cancer. This tumor DNA is directly detectable in the circulation using sensitive detection assays that identify tumor alleles amongst the far more abundant normal alleles that exist there in circulation. and provides promise for both early detection and monitoring, as well as detection of resistance mutations and for sampling tumor heterogeneity that you often can't fully appreciate due to the sampling effect of biopsying the tumor directly. In the field of circulating tumor DNA, while it holds a great deal of promise, it's still very much in its early stages, and there's many challenges and opportunities around which I'd like to structure this section of the talk. One of those is sensitivity, and as I already alluded to, this arises out of the low abundance of circulating tumor DNA relative to normal DNA in the circulation. This is the needle in the haystack issue. We also need to better understand the origins of cell-free DNA in individuals who don't have a cancer and in those whose cancer is in remission, and this will allow us to improve specificity. That is, what's different about the circulating tumor DNA fraction in individuals with cancer. We also don't fully understand what the nature of the temporal variability is in ctDNA. For instance, before and after therapeutic interventions like chemotherapy or radiotherapy. In order to have a frame of reference in which to place circulating tumor DNA and the alterations it contains, we need better radiogenomics and radiation oncology, and a better understanding of how these variants drive therapeutic response, sensitivity, and resistance. Finally, we collect a great deal of clinical, and in radiation oncology, we collect a great deal of dosimetric data for the patients who we treat. And I really think we need a way to integrate genomic information, such as that derived from cell-free DNA in the circulation, with the clinical and dosimetric data we already gather in order to better predict who will respond well. And this includes both tumor DNA as well as DNA derived from the tumor microenvironment, which we have access to in the circulation. As we think about improving the sensitivity of circulating tumor DNA, we can really approach this in several ways. One is more targeted high sensitivity detection of individual alterations, for example, in EGFR mutant lung cancer. And here we can employ techniques such as droplet digital PCR to find that highly unique variant that's present only in tumor cells. This approach is prone to some issues, one of which is that oftentimes these actionable mutations that are detectable both in the tumor and in circulation are amenable to targeting, and as a result, when tumors recur, they often drift away from these mutations, and that renders their ability to be useful as a biomarker a bit mute. There's also the approach of parallel analysis of widespread changes across the genome. Again, we have the opportunity to do this in cell-free circulating DNA for the detection of low amplitude signals that occur across the genome, a so-called signature that can contain gene expression differences, methylation differences, deletions, insertions, and translocation events, all of which are amenable to detection through sophisticated sequencing techniques that we now routinely employ from the circulating DNA fraction. And one such example is methyl enrichment sequencing, whereby we can use the methyl binding domain of the methyl DNA binding domain protein to enrich a fraction of whole cell-free circulating tumor DNA for the methylated fraction. And we can look in the depleted DNA, methyl-depleted DNA, as well as the methylation-enriched DNA for mutations and differential methylation profiles in order to increase the sensitivity as well as the specificity of cell-free circulating tumor DNA. Recall that tumors contain different methylation profiles, and that unlike genetic differences, which really don't exist between normal tissues, epigenetic tissue-restricted methylation patterns often allow us to distinguish the source of the DNA in a way that mutation profiling would not. So, this is just one strategy we can employ to improve the sensitivity and specificity of detection of tumor in the circulation. Moving on to temporal variability in circulating tumor DNA. We now are quite comfortable with the idea that many point mutations and alterations that occur in the primary tumor are detectable at high frequency and with high fidelity in the circulation. And we've been able to profile how this pattern of mutations that are detectable in the circulation changes over time. And this is just a single case report from our colleagues at Guardant Health in a patient with metastatic urothelial cancer, looking at the mutation profile at the time of diagnosis, at the time of complete response to chemotherapy, in this case GemCis, and then at the time of recurrence, where the key point is the mutation profile differs from that was present in the primary tumor. And this really gets at this issue of tumor heterogeneity, which is one of the strengths of molecular characterization using self-recirculating tumor DNA as opposed to tumor biopsy. The key point here being that tumors are heterogeneous and that different clones can be selected for by different therapies, and that biopsying a site in the tumor can give you a limited picture of the overall burden of a patient's disease, both in the primary tumor, which is again heterogeneous, and with respect to metastatic sites that can harbor very different clones than those occurring in the primary site. And so it would underline this idea that by examining the circulation, we may get a more comprehensive picture of the mutational burden occurring in the tumor and may be able to utilize a more inclusive molecular profile for the purposes of therapeutic selection and treatment monitoring. And so while this heterogeneity exists and we can detect it, we have to know what to do with it. And in order to understand what a particular molecular profile means for an individual, we need a better frame of reference. We need to understand how these genetic profiles and this map of tumor heterogeneity relates to an individual's sensitivity to a particular therapeutic approach, for instance, radiotherapy. And in this arena, we're working towards better radiogenomics. That is, a better understanding of how a genomic signature predicts radiosensitivity. And to this end, I'd like to highlight the work of several of my colleagues here at the Cleveland Clinic, in particular Dr. Mohammed Abazid and Jacob Scott, who along with me lead the Center for Personalized Radiotherapy at the Taussig Cancer Center. And Dr. Abazid has really been a leader in defining the genetic basis for the variation in radiosensitivity, both in cell lines and primary tumors, and cataloging those both genetic and epigenetic alterations that are causally related to radiosensitivity and not simply associated with it. And taking this a step further, Dr. Scott has utilized mathematical modeling to really reimagine how we think about the linear quadratic model of radiation response in the context of a radiosensitivity genomic signature to move us in the direction of individualizing radiation dose for individuals with a particular tumor based on that tumor's genetic profile. And I really think approaches such as these, innovative ways to think about the relationship between genetics and radiosensitivity, coupled with improved non-invasive detection using strategies such as detection of circulating tumor DNA and the utilization of that DNA for genomic profiling, are going to define the future of personalized radiotherapy. And so lastly, I want to spend a minute or two just talking about how we might better integrate clinical and dosimetric data in radiotherapy with genomic profiles such as those derived from circulating tumor DNA. Those of you who are familiar with radiation therapy will recognize the dose volume histogram, a standardized method of measuring the dose to an individual tissue based on the normalized volume receiving a particular dose. These are often used to define dose toxicity relationships. And what you're looking at is a figure of several hundred dose volume histograms colored by those patients, in this case, who received prostate radiotherapy, who had a good outcome with respect to sexual function or a poor outcome with respect to sexual function. And I think just qualitatively you can see that the red and blue lines, although they kind of are spread all over, fall into two categories here. And this is the kind of crude way we might distinguish the relationship between dose and toxicity. We might look at several of these data points plotted along the dual axes of the dose volume histogram and separate these dose volume relationships by those patients who had a low or high grade outcome with respect to toxicity, and use that to generate gradient maps to determine what the precise relationship is between dose of radiation to a particular volume of a particular structure and outcome with respect to normal tissue complications. And we can see that there's regions of the dose volume histogram in a particular patient, in this case the dose to the neurovascular bundles that pass posterolateral to the prostate, and the toxicity associated with injury to those structures, specifically erectile dysfunction. And what we find when we analyze these gradients is that there are vulnerable regions, anatomic regions, that define avoidance structures for dose minimization to maximize quality of life outcomes. In this case, we find that the cavernosal nerve at the apex of the prostate appears to be a vulnerable region for Schema decline, and Schema is the sexual health inventory in men, a measure of sexual quality of life. And the point I would make here is that this really offers us a rather crude picture of the relationship between radiation delivery and normal tissue injury, and taking it a step further, even tumor control, because it lacks information about tumor biology, such as that we can derive from tumor and normal tissue and tumor microenvironment genomic profiling. And so a challenge for us as we move forward is how to better integrate genomic signatures with clinical and dosimetric data to better define both tumor control as well as normal tissue complication rates. And so to summarize, we've discussed how integrated approaches combining genetic and epigenetic profiling can help us improve sensitivity of circulating tumor DNA detection, as well as define the origins of cell-free circulating DNA, improving specificity. We've talked about how tumors are characterized by primary site and metastatic site heterogeneity, and how there can be temporal variability in ctDNA, which we can use to our advantage to characterize tumor heterogeneity and better select therapies and better detect early emergence of resistance. I talked a little bit about how we're making strides forward in radiogenomics to apply a framework within which we can use genomic profiling to stratify patients into resistant and sensitive subgroups. And finally, I talked about the need to integrate genomic information and molecular profiling with available clinical and dosimetric data to maximize tumor control and to minimize toxicity from radiotherapy in our patients. And I'd like to close with this cartoon, which I really like because it reminds me that we have a responsibility to our patients to hold these emerging and very promising technologies to the highest standards of efficacy, to provide the maximum value, as well as to improve long-term outcomes for our patients. So I'd like to acknowledge my excellent colleagues here at the Cleveland Clinic, as well as my former colleagues at Johns Hopkins who are now collaborators on the studies I described, as well as the members of my lab. And I'd like to thank you for logging in and joining us today, and thank you very much for your attention as we move now into the discussion phase of this webinar. Please note I've included my email address at the bottom of this slide. Feel free to contact me for clarification or for a discussion of anything that we don't get to in the remaining section of this webinar. So once again, thank you so much.
Thank you for your presentations, Omar and Amy. It is now time for the Q&A. To ask a question, all you need to do is press the Ask a Question button on your console, type in your question, and press Send. So our first question, and this one asks, what is the typical format and amount of material you get from a prostate bladder cancer patient? Omar, is that something you can help answer?
Sure. Thanks, Jayshawn. Well, it can vary quite a bit. It really does depend on the method of acquisition of that tissue. For instance, in the case of a prostate biopsy, typically these are core needle biopsies that are obtained by our urology colleagues. They tend to be fixed in and paraffin embedded. In the case of prostatectomy or in the case of bladder cancer where you can do a surgery to remove the bladder, you have tumor in situ there, and that produces some other kind of complications in terms of the amount of material and the relationship of tumor to normal tissue within that specimen. For instance, the prostate tumors can be very multifocal. They can exist in a small part of the prostate. They can exist throughout the prostate. They can be low and high grade tumor in different parts of the whole mount specimen. And so being able to kind of micro dissect away tumor from normal tissue is an important of molecular characterization. And we do have to contend with this issue quite a bit in archive specimens or in cumulative tumor tissue of dissecting away signal from normal versus tumor and the proportion of tumor allele that we might be analyzing. And, to what degree is environment important as well. So I think that's a good question. It raises a lot of issues in terms of how we handle complex specimens and always straightforward. I hope that that kind of answers that.
I'm sure it does, Omar. And our next question is also directed to you as well. And this one asks, why did you choose this technology versus a sort of a more comprehensive RNA-seq analysis?
Yeah, good question, and a good follow-up to the last question for a couple of reasons. One is this ability to sort of use a very small amount of starting input material so that we can take that tumor, the small cell bladder cancer component of a formalin fixed and paraffin embedded piece of tissue and profile that specifically. And perhaps Amy can talk in a second a little bit more about how the HTG assay is useful for this sort of subcategorization of component of a tissue specimen. The other reason, gets at this trade-off between more comprehensive expression profiling that you might get from an assay like RNA-seq or a microarray assay versus the HTG oncology biomarker panel, which as I described to you has about 2,600 genes in it. The trade-off that I'm alluding to is one between integrity and comprehensiveness of genomic profiling. In the case of these very old fixed and embedded specimens, being able to do reliable expression profiling can sometimes be a challenge. And in particular for some of our older specimens, 10 years and greater, we found that the RNA integrity was really quite poor when we used extraction methods. And the RNase protection approach, which is an in situ hybridization and probe sequencing approach, again, that Amy can probably describe in a little more detail, gets around this issue of extracting. And so we were able to take our 40 or so bladder cancer, small cell bladder cancer specimens and get reliable data for nearly all of them. And so for us, reliable gene expression data for a majority of our limited data set seemed more important than cataloging every single gene that was in there, since we're kind of interested in a core group of tumor suppressors and oncogenes. But maybe I'll pass that over to who can tell us a little bit more about discussions that we've had along the lines of which technique may be better for expression profiling of archived specimens.
Yes, Dr. Mian, as he's alluded to, essentially when we developed this technology, we really developed it keeping in mind the clinical samples that most of the translational researchers are working with. And of course, this is the PE specimen. And we really developed this technology to work well on that particular specimen, as well as with sample input amounts that are typically seen in the clinic as well, keeping in mind that for a lot of different tumor types, we're driving to smaller and smaller amounts of input material. And this is quite critical to be able to work with this small amount of material to get that comprehensive profiling in order to build out these different molecular classifiers. So this is really something that we kept in mind in putting this entire technology together, making sure that it works well for that sample type that is most prevalent in the clinic.
Excellent. Thank you both for that answer. And our next question asks, does the age of the FFPE specimen impact the results? Amy, is that something that you can answer?
Yeah, absolutely. And I'll let Omar chime in on the back end as well in terms of the age of the samples that he had profiled. But essentially, we've worked with blocks that are 30 plus years old. And of course, these work quite well. So we're able to profile samples that are quite new in nature as well as quite old.
Thanks, Amy. Oh. And Omar, do you have anything to add? Sorry.
No, I mean, I totally agree with that. In our hands, 10 years seem to be a kind of meaningful cutoff in terms of high and low quality RNA extracted from fixed tissues. That said, we had a relatively small and homogeneous group of bladder cancer specimens. I think probably it varies with tumor site and with storage and fixation technique. But this is a real issue. We have this tremendous resource of archived tissues here at our hospital and around the country, sometimes associated with robust clinical annotation, as happens in things like cooperative group trials. The appropriate to analyze these tissues as we start to think more and more about molecular profiling and genomic classifiers. The appropriate way to analyze these tissues, I think, is a bit up in the air. The methodology that allows us to get producible, reliable genomic information from samples that can be very variable in terms of how they were extracted, how they were stored, fixed, extracted. I think that's an important issue. And in our hands, the OBP assay seemed a very nice way to get consistent data across multiple different age samples.
Excellent. Thank you both. And our next question asks, can you speak to the integration of your methylation data with the HTG gene expression data sets? Omar?
Yeah, another good question. So we have just started to look at that. As you may recall from the present, we had about 40 tumor specimens, and we have a handful of those, about 6, for which we had adjacent normal bladder tissue to compare to the corresponding tumor, as well as several metastatic site tumors. And those are the ones we've prioritized for epigenetic profiling to kind of get a sense of what are the epigenetic changes that mark the difference between normal and tumor tissue in any single individual, and then from that draw conclusions, if we can do that, about kind of more broad epigenetic pattern shifts and epigenetic reprogramming that occurs in the process of tumorigenesis. Also been embarking, and this is very much in the early phases. I'm not going to have a lot of conclusions to give you, but I'll tell you that we're starting to look at that, as well as trying to look at neuroendocrine tumors and small cell tumors from other sites in the body, for instance, small cell lung cancer, to see what are the similarities and differences there. So I would just say stay tuned on that front. My personal feeling is that the epigenetics is going to a very interesting story, but it's not quite complete yet.
Excellent. Thanks, Omar. And I think we've got time for one last question. And this one asks, have you looked at CNA in FFPE tissue and cfDNA from the same patients? Is that something that you've done, Omar?
Yes, and I assume CNA here means copy number alterations, and yes, so we have, although not necessarily focused on copy number alterations, our cell-free DNA, we've looked at it in a couple different ways. Some allow us to detect copy number alterations. For example, if we have enough sample there, paired-end next-gen sequencing allows that. Otherwise, droplet digital PCR and more focused detection methods look for individual mutations that we can go back and correlate to either clinical samples and tests, for example, Foundation 1 tumor profiling, or our own efforts to sequence the primary tumor. And I'll say that it varies across different types of lesions within a tumor, the degree of concordance. For instance, mutations that are driver mutations tend to be more highly correlated. These are single amino acid changes that, for instance, in, like I mentioned, EGFR, FGFR, things like that, where they seem to be important in driving tumor progression and behavior. Those seem to be highly correlated, and you can detect them. Copy number alterations, insertions, deletions, rearrangement events, at least in genitourinary tumors, these lesions, which we look at in an effort to do a kind of more integrated genomic profiling, these lesions tend to be less well correlated. But I'll qualify that by saying that, at this time, we don't have a large enough data set of cell-free DNA and primary tumor specimens to make any definitive conclusions about the fidelity of any individual lesion across all these different specimens. It's a very important question that this audience member brings up, because it gets to the future utility of circulating biomarkers in representative sample from the primary tumor. I'll also just point out one additional thing. The technique that the ground truth lies in the tumor specimen and not in the cell-free DNA, and that can be confusing. When there is not a complete overlap in the lesions, it does not necessarily mean that we've gotten the cell-free DNA wrong. It just may mean that you're capturing a different swath of tumor heterogeneity, either from a single tumor or from a tumor that has metastasized, where you have different clones, perhaps in different parts of the body. And you can see, our goal is to get to the point where you can see this in circulating, in a sensitive enough circulating assay, in a way that you may not be able to see by biopsying the tumor or even taking out the tumor, due to the sampling artifact that happens when you look at a single piece of tissue. So it's interesting, people debate this, the primary tumor is better, the circulating biomarkers are better. I think that in different scenarios, one or the other is going to turn out to be more or less useful, and in reality, we're probably going to, for the near term, be dependent on both. But, as anyone who has been involved in any clinical trial can tell you, it's now quite standard as a correlative study to look at circulating biomarkers, especially nucleic acid biomarkers. And I think that what we're going to see over short amount of time is that we're getting more information about how well reproduced tumor alterations are in circulation, and I think it's a really exciting time to be thinking about liquid biopsy and how we can innovate in that space. So yeah, great question.
Excellent. Thank you, Omar. Well, I'm afraid that is all we have time for today. Before we depart, please can you spare a few seconds to fill in the post-webcast survey that will appear shortly. I would like to thank Amy Wen and Omar Mian for their presentations and for answering your questions. I would also like to thank the webcast sponsor, HTG Molecular Diagnostics, and of course you, the audience, for taking the time to be with us today. Remember, you can watch this webcast again at any time on demand at nature.com webcasts. Thanks for watching, and I hope you'll join us again soon.